Welcome back, everyone, and thank you for being on time. If you are joining us for the first time today, we have a full afternoon planned for you that includes polling and session evaluations, amongst other things. Also, for our viewing audience, if this is your first time with us, just a reminder that using an Ethernet connection instead of Wi-Fi and using Google Chrome instead of Internet Explorer may help to increase webcast streaming speed and prevent delays. We are featuring polling during our event today. Thus, if you have not reviewed the polling instructions, please review the participant instructions document that is posted to the CTEO website via the link that was emailed to you this morning. Also note that if you have a question for our presenters, you can submit your question anytime by following the SurveyMonkey link that is also posted on the website. For those of you who are here with us in Baltimore, session number 7 presentation was printed and is available outside the auditorium if you would like to pick that up. I am happy to introduce our next speakers who will provide information about the variation in MA and PDP CAHPS scores across contracts and states. They will also describe tools available to contracts to help improve the experience of enrollees in health and drug plans. From the Division of Consumer Assessment and Plan Performance, please help me welcome Liz Goldstein and Sarah Gallo.
Good afternoon. My name is Sarah Gallo, and I will start off this presentation on Medicare Advantage and prescription drug plan performance on CAHPS measures. For those of you that don't know, CAHPS is the Consumer Assessment of Healthcare Providers and Systems Survey. In this presentation, first I'll give some background on CAHPS, describe the Medicare Advantage and prescription drug plan CAHPS surveys, go over the plan reports that CMS provides to all contracts, and show some state and national data from last year's survey. Liz Goldstein will then give some quality improvement resources focused on CAHPS and talk a little bit more about CMS's stratified reporting initiative. We'll leave you with some resources where you can learn more, and we'll also take questions at the end. Could I have the next slide, please? Thanks. Okay. CAHPS surveys focus on how patients experience or perceive key aspects of their care. This is different from patient satisfaction, which focuses on how satisfied patients are with their care. Patient experience surveys focus on asking patients whether or how often they experience critical aspects of healthcare, including communication with their doctors, understanding their medication instructions, and the coordination of their healthcare needs. CAHPS items and surveys are known for their rigorous and scientific development and evaluation processes. These include receiving input from patients, providers, and other industry stakeholders. The surveys and administration methodologies undergo extensive testing before they receive the CAHPS trademark. The CAHPS surveys use a core set of questions administered to all respondents in a reliable manner. The data collection protocols are standardized to ensure that information can be compared across healthcare settings, and the results convey information that is important and meaningful to patients. Over the past 15 years, the CAPS Consortium has established a set of principles to guide the development of CAPS surveys and related tools. Some of the principles include focusing on aspects of care for which patients are the best and/or only source of information. The surveys also focus on matters that patients themselves say are important to them. Another principle is that these surveys ask patients about their experiences with and ratings of their healthcare providers and plans. These reports of actual experiences are more objective than general ratings, and they're also more useful for quality improvement. And that's what we'll talk about in the later part of today's presentation. CAPS surveys are an integral part of CMS's efforts to improve healthcare. Some of the CAPS surveys are used in pay-for-performance initiatives to ensure that CMS is paying for high-quality healthcare services. Some of the CAPS surveys currently implemented by CMS include the hospital CAPS, home health, fee-for-service, MA and PDP, in-center hemodialysis, Medicaid, hospice, accountable care organizations, outpatient ambulatory surgery, physician quality reporting system, and the merit-based incentive payment system. But the focus, as we said, of today's presentation is on the MA and PDP CAPS. CMS collects information about Medicare beneficiaries' experiences with and ratings of MA and PDPs using these surveys. They're administered annually using a mixed-mode data collection protocol, and it includes 2 survey mailings and telephone follow-up of non-respondents. The questions on MA and PDP CAPS include ease of getting needed care and seeing specialists, getting appointments and care quickly, doctors who communicate well, coordination of members' healthcare services, health and drug plan providing information or help when members need it, ease of getting prescriptions filled, rating of health or drug plan, rating of healthcare quality, annual flu vaccine, and pneumonia vaccine. We publicly report these results for each contract in the Medicare and You Handbook that's published each fall, as well as on the Medicare Plan Finder website that you'll find at medicare.gov. Those survey results are used by beneficiaries to assist in their selection of a contract, of an MA or PDP contract, and the results are also used by the public to assess the Medicare program. And of course, contracts can use these results to identify areas for quality improvement. Since 2012, several measures from MA and PDP CAPS have also been included in the star ratings for MA plans. So each year, CMS provides to each contract, to each MA and PDP contract, a CAPS preview report that's used for star ratings purposes. So we try to get those out as quickly as possible so you can preview the results. But then later, we provide a detailed plan report, and that can be used by plans to identify areas for quality improvement. So I've included a few slides with sample kind of screenshots of plan reports. This is sample data, a sample contract. It's real national data. Here you'll see the national average as well as contract-specific average for each health plan composite measure, getting needed care, getting appointments and care quickly, doctors who communicate well, customer service, and care coordination. And the last column of this table indicates whether this particular sample contract scored significantly better or worse than the national average. So that's the up and down arrow that you see. So for example, the sample contract scored significantly better than the national average for the customer service composite, and it scored significantly worse than the national average for getting appointments and care quickly. The composites that you don't see an arrow for, that indicates that there was no significant difference from the national average. So the plan report for each contract summarizes the strengths and opportunities for improvement using text as well. And this sample page for a sample contract indicates that this contract performed well on the customer service composite, and there are opportunities for improvement on getting appointments and care quickly, as well as on the overall rating of health and drug plan measures. The CAPS plan reports also include dozens of figures like the one you see here. This is for getting appointments and care quickly. This table shows the proportion of respondents that answered never or sometimes, usually or always for this composite. It shows this nationally, across the state, in this case Alabama, in original Medicare or fee-for-service, for the caps for the sample contract this year, as well as from last year, so you can compare, and for other MA contracts in the same market area. And that methodology is described in the plan report. And the statistical significant differences from the national average are again noted on the right-hand side with up and down arrows. The CAPS plan reports also show the frequency of responses for each item, and so this is so that you can really drill down within the composites. This figure shows the frequency and percent of respondents in this contract who said that their personal doctor seemed informed about the care that they received from specialists. In this case, 8% of beneficiaries in the sample contract said never, 12% said sometimes, 31% said usually, and 49% of beneficiaries said that their personal doctor always seemed informed about care received from specialists. People who said that they didn't see a specialist in the past 6 months were not asked this question, so that's reflected in the missing category. CMS also looks at the CAPS data across all contracts in many different ways. This chart shows the national MA average for getting needed care, as well as state-level averages of beneficiaries in MA plans. So the national average is the top bar, and we chose some random states here, Virginia, Ohio, Massachusetts, Illinois, and California as examples. And these now are actual data, actual 2016 CAPS data, and these were used for 2017 stars. Getting needed care is the composite measure made up of two items, one asking about how easy it was to get appointments with specialists and how easy it was to get care, tests, and treatment you needed through your health plan. Here you can see that Illinois has the lowest percent of beneficiaries responding that they always received needed care, and California has the highest percent of beneficiaries who said that they sometimes or never received needed care. I do want to point out, though, that CMS employs linear mean scoring, not top box scoring. Linear mean scoring is the official MA and PDP CAPS scoring, which represents an average based on all of the survey respondents. So that is, we use all of the data in calculating the scores and not just the positive responses, like I was pointing out. Here's a similar chart for the Getting Appointments and Care Quickly measure. This is a CAPS composite comprised of 3 survey items asking about getting urgent care as soon as needed, getting routine appointments in a timely manner, and seeing providers within 15 minutes of appointment times. You'll see that scores are somewhat lower on this composite than the previous composite. Virginia, Ohio, Massachusetts, Illinois, and California, the 5 states that I chose, are doing a tiny bit better than the national average of beneficiaries reporting that they always got appointments and care quickly. Ohio here has the largest percent of beneficiaries saying that they always got appointments and care quickly. Customer service is 3 items asking about how often a health plan's customer service gave needed information or help, treated beneficiaries with courtesy and respect, and had forms that were easy to fill out. Most states are doing well on this composite, but you can see there's still opportunities for improvement on the right-hand side of the graph. Massachusetts had the highest proportion of beneficiaries reporting that they always receive high-quality customer service. And Virginia has the highest percent saying that they sometimes or never receive high customer service. And moving to the care coordination composite, this composite is made up of 6 survey items asking beneficiaries whether their personal doctor has their medical records, seems informed about their care, whether there was timely follow-up for test results, how often the personal doctor discussed prescription medications, whether the beneficiary got help needed from the personal doctor's office to manage care amongst their providers, whether the personal doctor seemed informed and up to date about care they received from specialists. And here you can see that Ohio has the largest percent of beneficiaries reporting that they always received coordinated care. In addition to the MA CAPS survey, we also conduct a fee-for-service or original Medicare CAPS survey. And the results from that survey are also reported on Medicare.gov, and the goal of that is so that beneficiaries can make informed comparisons between MA and fee-for-service. This slide compares the 2016 results between MA and fee-for-service on 3 of the CAPS health plan composites. I chose these 3 composites because they may be easier to target for quality improvement, which we'll talk about in just a moment. On the Getting Needed Care composite, you can see that fee-for-service slightly outperforms MA. 64% of fee-for-service beneficiaries compared to 63% of MA beneficiaries reported that they always got needed care. MA outperforms fee-for-service on the Getting Appointments and Care Quickly composite, with 53% of MA beneficiaries reporting that they always got needed care, and just almost 51% of fee-for-service beneficiaries reporting that they always got needed care. And finally, for care coordination, the MA and fee-for-service scores are very similar for 2016. So we wanted to include just at least one measure for Part D in this presentation. And so here we have the Getting Needed Prescription Drugs composite, which includes items about how easy it was to use the prescription drug plan to fill prescriptions at a local pharmacy or by mail. And these are the 2016 results for prescription drug plans and for MAPDs. The results are very similar in that about 80% of beneficiaries say that they always got needed drugs. But still, there are opportunities for improvement, since some beneficiaries are saying that they sometimes or never were able to get needed prescription drugs. I'm now going to turn the presentation over to Liz Goldstein, who will discuss CAP's quality improvement resources.
Thank you. So the Agency for Healthcare Research and Quality, or it's often referred to as AHRQ, has a number of resources available to help improve the patient experience. So if you haven't visited their website to date, we definitely encourage you to visit it to help identify ways to improve care. If you click on this link in this slide, you will see the content on the next slide. So just as some background, the CAPS program is funded and overseen by the Agency for Healthcare Research and Quality, and it works with a consortium of public and private organizations. So in addition to AHRQ and its grantees, develop and maintaining the CAP surveys in the various settings, they also support the development of tools for quality improvement. So the CAPS Quality Improvement Guide is one tool that they have developed, and this is a tool they've been regularly updating. So a link to this guide is provided in the CMS plan reports. We used to provide hard copies every year to plans of this guide, but given its dynamic nature right now, we do provide this link. So the guide provides insights about how a health plan or drug plan can improve care and services using the CAPS data. So I'm going to highlight a few features of this guide and some of the information that's conveyed in the guide. So the CAPS Quality Improvement Guide has several parts. It starts off by giving you some information. I think this is really helpful if you haven't done quality improvement efforts, for CAPS in the past. Why is it even important to improve the patient experience? And I think, staff at any provider needs to have buy-in if they are going to implement quality improvement initiatives. So this guide really provides a compelling case for why any type of healthcare organization should focus on improving the patient experience of care. There clearly is a demand, I think we're all seeing it, a growing demand among patients for enhanced service experience, as well as there's a demand for greater participation in their health care. So this clearly has resulted in more pressure for all types of healthcare systems to find ways to be more patient-centered. So it's not just true for health and drug plans, but we work on, surveys in various settings, and it's true, in all of those settings. So, in addition, to being important to patients and families, we have seen that, good patient experience also is associated with important clinical processes and outcomes. We have seen, for example, that patient experience is positively correlated with the processes for care for both prevention and disease management. We also see that good communication with providers is related to adherence, to medications, adherence to medical advice. We are also seeing that patients that have better care experiences, which includes, communication, tend to have better health outcomes. And this has been seen in, various settings. So another thing to consider as you're embarking on quality improvement, are you ready to improve as an organization? So I think this guide provides some insights into that, as well as, things to start thinking about. They do provide in this guide, and I hadn't looked at it for a little while and was recently looking at it in more detail. So it provides some suggestions of behaviors to look for, and there are examples such as cultivating and supporting quality improvement leaders. And I think that's not only important for the CAHPS measures, but for all of the quality measures. Organizing teams responsible for improving patient experience. And we've heard this, from some of the plans that regularly come in to speak to us, that they have set up teams that are responsible for improving different aspects of care. It's important to train staff in the quality improvement concepts and techniques, paying attention to customer service, and really, as these teams embark on these efforts, you want to really recognize and reward success and celebrate them as an organization. Okay. The guide also provides a walkthrough of some of the basic steps for quality improvement initiative. And I think some of the things, really to think about is encouraging communication, engagement, maybe to start, if you haven't done, broad-based quality improvement initiatives related to patient experience, maybe start, in small-scale projects to see how they work and how you can tweak your processes before starting on some huge effort. I think also, in terms of the CAHPS survey, as well as other quality improvement efforts, to keep in mind that quality improvement will be an iterative process. So you're going to learn from what you do and make corrections and keep measuring to see if you've achieved your goals. So in this guide, they do put a lot of emphasis on the plan, do, study, and act processes. Also, what is very important is determine where to focus your efforts. And so, we'd encourage you to use the CMS plan reports to help target where you do have opportunities to improve, as well as to bring in other sources of information. Often we'll encourage plans to do some focus groups with beneficiaries to really understand where they do have some opportunities for improvement. The guide also provides a lot of information about some strategies for improving care. And I think here they list a lot of books and resources and tools to address the various issues related to patient experience. And I think it's helpful, to see these, to, just reviewing them may spark different things that your organization potentially could do. There are multiple strategies listed in the guide to improve, access to care, communication between providers and patients, coordination of care, and customer service. And I think when you review your options and what you want to focus on, it's really important to think about the appropriateness for your organization, the resources and time available that you have, and how quickly you feel like you need to see results. So I know all organizations have constraints, so a different strategy may be better for your organization. So as I said, the guide provides different resources for different measures. So on this slide, I just pulled an example of what is available for customer service. So, the CAP survey already includes a number of questions related to customer service. And these questions were developed with input from enrollees of health plans. So starting here, you can see, from the CAPS questions where you may have opportunities for improvement. And many, I think, health plans and kind of the recommendations from ARC is to develop standards, for your organization. So it may be, I'm just pulling some examples from the guide, but there are lots of other ones that, for example, 90% of patients who call for an appointment receive it the same day or within a certain number of days, or you're seen within a certain number of minutes when you get to a doctor's office. Or another example, our test results are communicated in writing to the patient after a visit. So there are different aspects and different targets, and each organization is going to clearly need to work with their staff and managers, to figure out what are the appropriate targets for your organization. Just to list a couple other resources available, this is a free webcast from ARC, and it focuses on innovative strategies from 2 Medicaid health plans, and it goes over, what quality improvement strategies they implemented for CAPS measures, some of the barriers they had and how they addressed them, and some of the key lessons learned. So this is, I think, a very nice webcast if you're starting off efforts. It's always nice to hear from other organizations and some of the challenges that they have faced. This is another resource, and this is a podcast, and it's an interview with Susan Edgman-Levitin. She's really a national quality improvement expert and has been involved in the CAPS survey process for about 20 years. In this interview, she goes through some of the differences between patient experience of care measures and patient satisfaction, and discusses some of the range of interactions that the CAPS survey captures, and how you might start thinking about improvement in these areas. Another resource, and I know some plans by questions that we've been getting have been starting to look at this, is the CMS stratified reporting. And this is really to understand your scores on HEDIS and CAPS. CMS has begun to provide information stratified by race, ethnicity, as well as some national numbers on gender differences. And this is to help you target your quality improvement efforts and see where there may be opportunities for improvement. So this is the CMS webpage with this information. So if you haven't looked at it, I would encourage you to look at it. And this information will be updated on an annual basis in April of each year. So as I said before, this stratified reporting is really a good resource for targeting quality improvement efforts, for monitoring your performance and really to advance the development of culturally and linguistically appropriate, quality improvement strategies. The next slide is just an example from what you can see in the stratified reporting. Currently, the contract level information is available by race, ethnicity. The gender information is available nationally. And this last slide provides some additional resources to our website, a couple of our mailboxes to get additional information about the survey or when you have any questions. So I think right now we wanted to open it up for any questions. We'd be really interested in hearing from you today or even at a future time. Feel free to contact Sarah or myself about any successful quality improvement efforts that you're embarking on or have completed, as well as if you have any suggestions for other types of resources that would be helpful for quality improvement. Thank you.
Okay, we have time for questions, so if anybody in the in-house audience has a question, please move to the microphone in the center aisle. All right, we will go to questions that we received from our viewing audience then. And the first one is, where and when do we get our CAPS reports?
So the CAPS preview reports are sent to the Medicare compliance officer by email each August. The full plan reports are mailed. They're on a CD and includes all of these various data files and PDFs. And that's mailed in September of each year, again, to the Medicare compliance officer.
Okay, the second question that I have, who can I contact with questions about implementing CAPS into my health or drug plan, or with how the data are used for Part C and D star ratings?
Any questions about the data used for, the CAPS data used for star ratings can be sent to that mailbox listed on the screen, mp-caps@cms.hhs.gov. But for technical assistance questions regarding the MA and PDP CAPS, please send those to the project team whose email address is listed there, ma-pdpcaps@hcqis.org, and we will get right back to you.
Okay, and I have one last question here. Who can I contact with questions about using the CAPS data that are stratified by race or ethnicity and gender?
So that work is led by the CMS Office of Minority Health, and they would be happy to take questions about stratified data and how health plans can utilize those data. They have a mailbox for questions, and it is healthequityta@cms.hhs.gov.
Okay, anyone else out there with a question? No? Okay. Well, I would like to then at this time thank Liz and Sarah for the information on CAPS scores. If you can join me, please. Okay, if you would like to evaluate this session, please take out those cell phones or go to that webpage and enter the letter A, and then follow that link. All right, I have just a couple reminders for both our in-house and our viewing audience. And one is that we will have an end of event survey that we will be sending out to you, or that you can complete via the polling at the end of this session. And we encourage you to take a few minutes and complete the survey and provide CMS with some feedback, so that as we move forward with planning events in the future, we can incorporate any suggestions or comments that you have. Also, we will be offering CEUs for today's sessions, and if you look in the conference guide, you'll find the information in there how to obtain the CEUs. And I know that there is also some information on the CTEO website. So please check that out, and so you can get CEUs for your time spent today. Up next, we have some speakers from CMS who will provide an update on the online directory review and share the most current information on the project. America's Health Insurance Plans, or AHIP, who conducted a provider directory initiative, will provide an overview of the initiative and lessons learned for the health plan industry. It is my pleasure to introduce to you from CMS, Carrie Casey and Jim Canavan, and from AHIP, Jeanette Thornton.
Hi. Good afternoon. I'm Carrie Casey from the Division of Surveillance, Compliance, and Marketing. And today I'm going to be giving you some background about CMS's provider directory review, as well as some reminders about our current provider directory guidance. My colleague, Jim Canavan, will be discussing CMS's provider directory review process. And finally, Jeanette Thornton, a senior vice president at AHIP, will be discussing AHIP's provider directory initiative. So as some background, our first review of provider directory accuracy ran from February to August of 2016. We reviewed 54 parent organizations and sampled 108 providers from a provider directory of each of those parent organizations. The providers were divided among PCPs, ophthalmologists, oncologists, and cardiologists. The review included 5,832 providers and approximately 11,646 locations. We found an average provider location error rate of 41%. So our current status is that we began the second cycle of reviews in November 2016. Our review this year is looking at the same provider types as last year, and plans are receiving their results on a rolling basis. So just as a reminder, the provider directory guidance is located in a few different spots. January 17th, 2017, we released an HPMS memo, Provider Directory Policy Updates. We also have information in Chapter 4 of the Medicare Managed Care Manual, and the provider directory model itself has instructions. So what I'm going to be going over today is the highlights of the provider directory memo. And we chose different topics based on common errors that we're finding in the provider directories that we review. So first off is a reminder that plans must include a notation identifying providers who are accepting new patients or a notation identifying providers that are not accepting new patients. So one thing that we ask is please make sure the meaning of that notation is clear. I've got a green check mark there, but you don't know what that means if I don't tell you. And that's something that we found in provider directories, that those notations are difficult to interpret. And again, we ask, don't assume that specialists are accepting new patients. There are times where specialists are not accepting new patients, and that needs to be noted in the directory. So today we're going to do some polling questions to get an idea of where the industry is at. So we're not asking for the compliant answer, we're asking what you all are doing today. So what notation does your provider directory use? And it looks like so far we've got 100% provider is accepting new patients. Our other options, provider is not accepting new patients. We are updating our directory to include this notation, and other is our final option. I'm going to wait a few seconds while people keep answering. Okay, well, thank you very much for this information. We can see overwhelmingly providers accepting new patients is the most commonly used one. And if you're working to update your directory to add this information, then that's great. We look forward to that. So another thing that we encounter in the directories is providers that are listed before their contract is effective, and also providers that are listed who are soon to terminate. There's a known termination date. And we want to remind you that if you're listing a provider prior to the contract effective date, that date should be included in the directory. Similarly, if a provider has a known termination date, include that in the directory, and you can see below an example of how that might be done. So to better understand where the industry is at here, when does your plan start listing a new provider in the directory? A, after the contract is signed before the effective date, B, on or after the effective date, C, other, or D, I don't know. Great, I appreciate the honesty of people who don't know. As long as the people in your organization who need to know, that's what counts. All right, so on or after the effective date looks like it has the most results. Similarly, when does your plan remove a provider from the directory? A, as soon as we know the provider's contract is terminating. B, on or after the termination date. Other, and I don't know. Okay. All right, so similarly, most responses are on or after the termination date. Thank you for that information. So another thing that we have want to highlight is plans must identify when a provider has significant limitations on the patients that they see. So one example we encountered was someone certified in oncology who practiced as a bone marrow specialist and only saw patients who were referred by their oncologist. Obviously, that's a significant limitation on who they see. Another example is providers that are only accessible to members of a Native American tribe. Along those lines, we're wondering, is your plan currently able to identify limitations on what types of patients a provider sees? A, yes. B, no. C, we're working on it. And D, I don't know. Well, it's very helpful to see there that a lot of people are struggling with that, and that's useful information from us. And again, if you don't know, please make sure the people at your organization who need to know do. So this next requirement addresses a very common problem that we've encountered in the directories. So directories may only include providers at those locations where plan members can schedule appointments. So here's some examples of what we've seen. Providers whose duties are administrative only, doctors who oversee clinics where only nurse practitioners and physician assistants see patients, providers at walk-in or urgent care clinics where appointments aren't scheduled with them directly, as well as doctors who have admitting privileges to a hospital but don't schedule appointments at that hospital. So, something we're really curious about, is your plan currently able to identify locations where a provider routinely sees patients? A, yes. B, no. C, we're working on it. D, I don't know. All right. Well, it's great to see how many people are working on it. That's what we really want to hear. This is very important to beneficiaries. So lastly, one thing we want to remind you all is that you must make clear what type of medicine a provider is practicing at a location. So this example is something we've commonly seen. So Dr. Smith has some sort of background in infectious disease, oncology, and internal medicine, and she practices at 2 locations. But I don't know for what conditions I would schedule an appointment to see this provider. So here's an example of something that gives you a much clearer idea of what the provider does. So she's certified in infectious disease, oncology, and internal medicine, but if I need an oncologist, I go to Main Street, and if I need an internist, I can go to South Street. So, our last polling question, is your plan currently able to identify the specialty of provider practices at a location? All right, well again, it's good to see how many people feel confident of that. And I just ask you, if the people who do this type of in-the-weeds work aren't here today, make sure that those people are aware of these things. And now I'm going to turn things over to my colleague, Jim Canavan, to discuss the provider directory review process itself.
Thank you, Carrie. So many of you have probably already gone through the process. Some of you may not have yet. And we're going to go over a little bit of what happens during that process. Then we're going to discuss some common elements that pop up during this that we see, things, best practices, things like that. And finally, we'll discuss, if you have any questions about this, where you can send them. So the process starts with our CMS contractor. And what they do is they generate a list of, well, they work with us to generate a list of what plans we're going to be reviewing. And then they generate a list of providers using our methodology that we've created for each of those plans. Then Carrie mentioned earlier how that breaks down, the 108 providers across the 4 different categories. Then the contractor calls each of the locations for those providers. So while there will be 108 providers in the sample, there will be more lines of data, is the best way to put it, because some providers have multiple locations. They give each of these reports to us based on their calls on a plan-by-plan basis. So when we see the data, we see it for one plan at a time. What we do is we look it over, just make some general observations, and then we pass it on to your Medicare compliance officer. And then we schedule a call with that person and with anybody else they want to bring to the call. The calls are very short. We schedule them for 15 minutes. They usually don't take more than 5-6 minutes. And we basically just explain what we're doing, what our expectations are, give some best tips, things like that. And then we give you 2 weeks to review the file. So what you'll do is you'll review the file and make notes on it in the appropriate places. We send a set of instructions along with the file to explain that. And then you return the file to us. We then go over the file and look at your responses. Sometimes they require additional calls that we can pass on to our contractor. Sometimes we'll make the calls ourselves. Sometimes it requires some other types of research. But eventually we make a final determination. Some of the findings are weighted more heavily than others, and we return that as your final results. Now, one thing we ask you to keep in mind is, as you're getting ready for this review, is that when we ask our contractor to review the provider directory, they're looking at your online provider directory and using only the data that's in that provider directory. So that's their perspective. They are using the perspective of a member who only has your online provider directory information available, because that's what we're evaluating. So they're calling these providers, they identify themselves as a CMS contractor, but they're calling with the perspective of a member trying to schedule a routine appointment. So when you're reviewing the data, we ask that, if you're going to use things like provider group reports or some type of credentialing report, we ask that you do so with a grain of salt. You can look at it and have that help you to determine, what your response is going to be. But keep in mind that those are for other purposes. Those are not for the purpose of determining whether or not one of your members, as a patient, could schedule a routine appointment. And finally, one of the things we've noticed is that certain providers, like surgeons, for example, will be listed at the facility where they perform surgeries, where that's not where they're going to have. That's where the member will go for the surgery, but for the purpose of scheduling routine appointments, they actually usually have an office or a clinic somewhere else, and that facility is often listed as a surgical center, something like that, or basically just you want to list facilities as facilities, and you want to list providers as providers. So if you have any questions during all of this, whether you have questions on a report that's already been done, or if yours is coming up and you want to make sure you're ready for it, please email us. You can email Carrie and me. You want to get both of us on the email address. And you also want to put the Medicare Part C policy mailbox on there, which is listed on the screen there. And that is it for me. So I think we're going to turn it over to Jeanette.
All right. All right, thank you. Hi, everyone. Thanks for having me here. With all of the focus from the CMS compliance perspective on health plan provider directories, we at America's Health Insurance Plans took a step back and tried to look at what potential industry solutions and what we could learn about how we could improve the accuracy and the timeliness of the information in our member health plan directories. I'm going to talk to you about a project we wrapped up earlier this year and share some insights, best practices, and I think this will help you as you're looking at complying with the Medicare guidance related to your Medicare Advantage plans. So I'm going to talk about the initiative, talk about some of our pilot work and evaluation, and sort of where we're looking to take this going forward. So I think many of you, in addition to participating in the Medicare Advantage space, also have other lines of business, whether it be commercial, Medicaid, exchange/marketplace, et cetera. And I'm sure you're aware that the providers that you contract with for Medicare also participate in your other networks. So we really wanted to look at this holistically and not just based on Medicare requirements, but more broadly. There is sort of a growing convergence around the federal requirements for a common set of data elements across different lines of business that have to be included in plan provider directories, and we've concluded a subset of them there. Medicare Advantage is unique with a new requirement, or not new now, probably about a year or so, that you have to do outreach to your contracted providers on a quarterly, it was originally monthly, basis, and the audits that are ongoing that Jim and Carrie talked about. There are also very specific requirements for those of you that participate in the federal marketplace, these machine-readable files, which I'm sure you've heard of, as well as new requirements related to Medicaid managed care that kick in this summer that really get at some more unique aspects of the Medicaid population, looking at a provider's cultural and linguistic capabilities. And those are some new requirements, some new things that plans are having to look at in terms of building out their online and paper directories. In addition to the feds, I think we've seen a growing amount of state focus on this, and while these state activities may not address Medicare specifically, they do address your other lines of business, so I thought it was important to include here. We do have an NAIC network adequacy model that does have provider directory requirements. The AMA has been pushing very specific requirements related to what has to be in a plan directory, but these have not yet been adopted. We've seen a number of states, either through legislation or regulation, adopt new requirements. I think the most significant of those are California's SB 137, which came into effect while we were doing our work, which has a lot of requirements for the plans, as well as a stick and a requirement that providers respond within a certain time frame. And then we've got additional activity that should be on the horizon for the remainder of 2017. So just wanting to make sure we don't think of this as just a Medicare issue, definitely much more broad. So in looking at this, as I mentioned at the outset, we really wanted to think about this holistically and worked with a group of our CEOs who are very interested in this issue and providing industry leadership to go through a competitive process where we selected 2 vendors that we could test different solutions to update plan directory data. We launched pilots, which I'll talk about, and we've just wrapped up our evaluation earlier this year. We wanted to think about how we could improve the quality and accuracy of plan directories with the Medicare requirements at the time that health plans had to call or email or fax providers on a monthly basis. We didn't think it made sense for every plan to have to call every provider's office. That'd be a lot of incoming calls every month, and wanted to think about this if we could work together as an industry. We wanted to reduce the number of calls and contact and really think about if we were ready at a point where this could be adopted on a national level. So we decided to go into 3 states, Florida, California, and Indiana. Florida and Indiana, we were specifically focused on the baseline requirements in the Medicare program. California, as I mentioned, had the new law, SB 137. And we took different approaches. We wanted to see where providers and their staff, who are most typically answering these requests, would be receptive to responding and getting back information to the plans who were contacting them on a regular basis. So in Florida, we tried to get at the administrative staff where they're already working with you, where they're submitting eligibility requests, submitting claims, and using one of the portals that's out there, Validity, where staff are already working with you on a regular basis. So we wanted to see if those kind of things were the best way to get at this. Better Doctor, a startup company out of California, took a different approach, and they used phone, fax, and a mobile tool that providers were basically given a link and able to log on. They saw their information as it's already presented by the health plans and were able to say yes, no, and make those updates as appropriate. So we took different methods, and I think it presented some interesting results that we'll talk about. So I'm going to talk about them a little bit differently just because there were different regulatory requirements that came into play. We contacted in Florida 51,000 providers. This wasn't a small pilot. And I think it's very interesting if you look at the very bottom. It took us to contact each provider's office 7 times to get them to respond. So what does that tell us? Well, providers are very busy people, but it took a lot to get their attention where they're trying to basically get the claims paid or check the status of a claim. So that was very interesting. The vehicle, at least in our pilot, and certainly this will be improved based on the lessons learned, presented them some challenges, and providers, maybe due to a lack of awareness, sort of deprioritized this over other administrative things. We did end up contacting about 35% of the providers in the pilot, and we had about 18% finished. So some even started this process and stopped midway. We asked them about 18 questions, and this is, gets to all of the different regulatory requirements and wanting to make sure that we're really, for the first time, going through this and updating all of their information. And also very much of interest, they had a lot of data changes. 63.9% of the data elements were edited by the staff during this process. And I think that aligns with some of the things that Jim and Carrie and their team have found in some of the audits as they've been looking at the data out there. So certainly we have improvements to make. Talk a little bit about Better Doctor. You can see the comparison and then sort of roll this up. So we contacted 109,000 providers across California and Indiana, and it's a bigger market. We got about 47.5% to respond, and this is because we called in addition to faxing and emailing, and of course, you kind of have to answer the phone. So it was, excuse me, it was easier to get a hold of them by phone, but one of the things is we've learned that providers don't necessarily like getting all those phone calls. We had 18.4% of the providers complete the validation request, and we started out this process using old-fashioned faxes, and I think you all know that providers are the last industry to love the fax machine. We hope that dies soon. But throughout this process, we switched to phone calls, and then they'd get a one-page fax that would drive them to a web page where they can complete the information. So they're not like faxing the information back, but that's just how we contact them, because we know that plans have fax numbers for their providers and are slowly building out email addresses for the providers in their network. So in California, it took a less number of contacts, starting with just over 2 and dropping that to 1.4, and that's just because of the phone calls. And to sort of wrap up the outcome, and phone calls also take a long time. We had to actually break them up into chunks to get through all of the required data elements, and California's state law has more data elements required than Medicare Advantage, but still took quite a long time, and we're able to end up walking through that in about 37 to 24 questions, depending on if you do it online or on the phone. And then again, similar to Florida, just a lot of data had to be updated. We were looking at almost a 55% update rate for what was in the plans directory. So let me talk about some themes and what this can mean for all of your work as you're looking at your Medicare compliance obligations. So it's very clear to us that providers know what health plan provider directories are. Very high awareness rates. We did do awareness rates. We did do a survey of all of the providers that participated in the pilot, an online survey after the fact. So they've heard of this, so that's not the problem. The general awareness is not the issue here. We also, as I mentioned before, learned that they really want an electronic way to respond to plans requests to update information. They want to have an email. Some still, like I said, love the fax machine. I don't know why. But phone, which has been a way that plans have done these updates, is much lower on the scale. So something to think about. We'll talk a little bit about this, the importance of a multi-channel approach where you start with one method and move to another. I think it's important to think about as you're looking at how to update your data on your network. So we got the biggest response, as I mentioned, but via telephone. Phone call, 40%. Fax seemed to work well. And again, if you've ever looked at a fax machine submission, you don't want to be having somebody transcribe that information you get back. You really need to drive them to an online capability. And again, the portal, while it did get some responses, it wasn't, at least in our pilot, and this can certainly change as vendors get better and this process evolves, finding a provider where they're doing other things with you didn't get the most response, and that may very well be because they're busy and they want to get those claims paid and other sorts of things. So one of our conclusions, their preferred method may not be the most effective. We want to move to email and electronic outreach, but some of this can be deprioritized or disregarded. Phone outreach can also be very burdensome, especially when you have if the plan contracts with if a provider contracts with a number of different health plans and they have each one of those contacting them on a regular basis. So one of the things that we're asking plans to think about is how to balance that burden with the most effective outreach method. And you may have to use more than one outreach method to reach providers in the best way, in the most cost-effective manner. We also thought that it was very important to cultivate that trust with your provider, and that starts with building awareness and wanting to pursue a flexible approach. So really important to talk to the providers in your network and see how they want to be contacted to get these updates, wanting to let them know how their data will be used and protected. They may get contacts from a vendor that, while they don't know that you're working with that vendor, and how do you clearly delineate that vendor X is working with health plan Y? We also had very good success working with provider organizations and specialty societies. They want to be helpful here. excuse me, on behalf of their membership. And they also, we also learned that it was really important when you do newsletters or emails or other sorts of regular contact with your network that you tell them, you know, this vendor is going to be contacting you to update your information. This is what we're going to be doing. Here's where your data is going to be used. That we heard a lot about that from our providers. They would fax back some of these pages and say, you know, who is this? Who are you working with? And really wanting to make sure that that data was secure. So we had to make it easy for providers to confirm the vendor's role. We definitely learned through this process that we have different approaches used at different plans, whether you store the data different, you manage the data differently, and that posed some challenges when working with a unified or a vendor that worked with multiple health plans. We also talked a lot about provider contracts. I don't know if you all know this, but we learned through this process that many health plans already have language in their contracts that whenever they change information, they move across town, they move suites, they update some other information, they have to contact you. But we didn't necessarily think that that was actually always happening in practice or that was uniformly enforced. And I think this puts plans in a very difficult situation. You do not want to remove this provider from your network for something like this. On the other hand, you want to ensure that the beneficiary and the consumer is getting accurate information. So it does create some challenges there. And we didn't think that many of the providers really understood that they did have this in their contract. I don't know, before bed, you probably don't sit and read your contracts, but we definitely know that providers didn't realize this was in there. And I think this goes back to what I was saying about the carrot and the stick. All of the burden and the compliance right now is on the plan. There's no kind of corresponding incentive for the provider to respond in a timely way. And the leverage that you have, whether that's delisting the provider from the directory or removing them from the network, is not always practicable, or is it not always the best thing for consumers? So definitely learned about some of the challenges there. But we definitely still think this is one tool that plans do have in looking at the contractual requirement and figure out ways that you could hold providers accountable if they aren't responding to your requests. All right, I talked a little bit about this already in terms of that uneven or unbalanced accountability, so I won't belabor the point, but I think everyone knows we're busy, providers are busy, they get a lot of calls from various entities out there, and we have to think about the best way to engage them on this issue, or we'll continue to have challenges where plans are sending data requests and we're just not getting the responses. You know, we've thought a lot about this, and I think, needing to start with those carrots, those positive incentives, increasing education, not just the fact that plans have directories and it's important for them to be accurate, but how can we instill a greater sense of collaboration with our providers to ensure that they are responding and you're the first one they call when they make a change to their information that could impact consumers being able to find them. And finally, this isn't the most, sexy topic to talk about, but it's important. Technical standards. There's still some work to be done in this space when you're talking about collecting data, taking data from a vendor and then sharing that back to you. So you can take that data and then quickly turn that around and put in your provider directory as soon as you get it. It presents some challenges for plans. A lot of problems with export of files, imports of files, and being able to not to have somebody look at spreadsheets and manually update your provider directory. We don't want that. There are a lot of other groups working on standards. I know X12, CAQH has done a lot of great work in this area, and California is also investing a lot of resources in standards development, so I think we'll get to some solutions on this piece soon, and it'll definitely be necessary as we have more cross-plan collaboration and vendors in this space. I think it's also just important to answer the question, do your providers know what to do if they have a change in information? Is it your portal? Do they call? Do they fax? Like, what is the process that providers need to do? So you can get those data requests proactively before you're doing your quarterly outreach. We also, I think it's also important to have a channel for how consumers can report changes or issues with the directory, and those can be investigated by teams and then result in updates to the provider directories. So a provider to make it easier to ask a question. The last thing I'll say is that there needs to be greater standardization in the process and channels for providers and consumers to flag issues. I think this is really important. Consumers are using mobile tools, iPhone directories, things like that, to be able to find a provider, and if they find something wrong, there should be an easy way to try to flag that for you. Very small words, but we did collapse sort of all of the lessons learned together in one slide. We have an issue brief on this that has all of this for you and your teams if it's something that you're interested in learning more. We have also done some detailed webinars that your team can download and listen to if your network people want to learn more about what we learned and strategies to work on provider directories. So all that's available on our website. You just have to search for provider directories. So I encourage you to take a look at that if that's something that you're interested. And I will say that we'll continue to work on this. We know how important it is for consumers to get good information on plan directories, and we definitely think it is an important initiative for the health insurance industry to be focusing on in both the near and long term. So I appreciate you having me today. I hope I was informative and look forward to your questions.
Okay, do we have any questions from our in-house audience? Please introduce yourself and let us know where you're from.
Hey, good afternoon. My name is Tom Hennessy from Johns Hopkins. As Jeanette aptly noted, the burden is on the plan to make sure that these issues are resolved. And I have a question to the CMS members on the stage. Has CMS given any thought to working with the plans to help bring awareness to this on the provider side so that we're not out there just knocking on a door by ourselves to try and get them to give us the information that we need? Providers change information on a whim, and oftentimes we don't find out about it until a member shows up at the office or calls and has a question. So just wondering if CMS would do something in its role as a national overseer of healthcare in this country to help us to work with the providers.
So I would say that we have received that feedback and we appreciate it. And if there are specific suggestions about things that we might do, we're always interested in hearing them. For us, the contractual relationship involved is between the plan and the provider. And so we have to keep that in mind, that the relationship is between the plan and the provider, not between CMS and the provider in this particular instance. But we're always open to suggestions about what we might do.
Just to add to that, we have received interest from other parties as well in assisting with that sort of project.
We would love it.
Thank you.
Hi, Mike Sneckenberger, Anthem, and he took my questions almost exactly verbatim, but wanted to kind of just, mention it here also as the kind of the push behind it too, I would say. Thank you.
Thank you.
Hi, Elizabeth Lippincott, Strategic Health Law, and I have a question for CMS panelists. Do you anticipate expanding the specialties or types of providers that you'll be reviewing in future years? And if so, do you have any plans to look at behavioral health?
We haven't finalized our plans for the next cycle of review. I would say that we have been happy that our first and second cycle reviews are comparable. So we know that the data is similar and we can better identify improvements because we haven't made changes like that. If you all have feedback that would be an important step to take, certainly send it in to us and we'd be happy to consider it.
We have a question up at the front, Mike.
Linda Howard from Alternative. I have a question in terms of the effective outreach to providers. We know we're not getting 100%. So are there any benchmarks in terms of us making a determination as to what is an effective method? So for instance, there were some data in terms of this got 47% response, this may have gotten a 21% response. What should we be using as a benchmark to help us determine what's effective and what's not effective?
So CMS doesn't have a benchmark. I can tell you that during our process, what we do is we call providers, and that is the best. We get a decent response. Our contractors tell us when plans refuse or providers refuse to participate, and it's very rare. So I can say that we use phone calls. I think AHIP and other organizations that are doing their own research may have some feedback for you also, something to look at, but CMS doesn't have a benchmark.
Thank you.
Andrew Finkelstein, Health Partners Plans in Philadelphia. Referring back to the first question, if CMS could provide some more information, to the extent that CMS might have other provider demographic information through, for example, enrollment, provider enrollment, notwithstanding the contractual argument from CMS, is there any intention on the part of CMS to use that information that the plans could rely on? Sub-question to that is whether or not there's any future plans on the part of CMS to use the data that it's acquired through this pilot and make that publicly available to the extent that there may be accurate demographic information that CMS has collected through this program.
Your second question, we hadn't considered that. We would have to think about it. I'm not sure how appropriate it would be given that it was plan specific, although we could remove the plan data, obviously, but it was drawn from specific plans, and so we would have to think carefully about whether or not that was a really reasonable, appropriate thing to do. And in terms of CMS data around providers, some of that is available online already. It's not handled on the Medicare Advantage side, but there is some, and it's information for us to think about in terms of what we could do there, and appreciate the feedback.
Thanks.
Yeah, I'll add from our pilot and what we saw. One of our vendors actually took all of the plans. We had 9 plans in California participate and aggregated their information and sent reports back to the plans. And you could see both issues with how plans normalize the data, like first, middle names, nicknames, all of that information was not standardized across the plans. And even that work is very difficult to clean up and important. If the provider goes by Bobby, you want to know that have that correct. So there's certainly an emerging vendor segment out there that will gladly take your money, I guess, and do this. But I think it isn't important to be able to leverage all of those sources of data that are out there, because there is a lot of data that's out there.
Hi, Mike Adelberg, Feggery Baker Daniels. To the degree that Jeanette was talking about moving toward carrots and sticks to greater incent providers to take keeping the directories updated seriously, at least the sticks part of that could result in provider complaints, terminations of certain providers that might conceivably result temporarily in dropping below on the network adequacy spec. And I'm just wondering the degree to which CMS has thought about the push-pull of different requirements and whether it's possible for the plans, if they do choose to step up the pressure on providers, the balloon might get squeezed and the balloon might pop somewhere else.
Well, I mean, again, mostly what we're discussing here is the contract between the provider and the health plan. Then we don't really have a lot of sway over that. But from our perspective, certainly we've considered all sorts of aspects of how this could play out. And we are always keeping in mind our goal that we want accurate data in the provider directory so that your members, Medicare beneficiaries, will be able to get the care they need where they need it. So, I mean, certainly, yes, we do consider all those, and that would be a consequence, a definite consequence. But at the same time, providers do want to get paid. So they are going to continue working with insurance companies where they can. And that matches my own experience with clinics, I guess is the best way, a clinical environment.
Yeah, Mike, I think that's a really good question. One of the things that was very unique about the law in California is it gives plans the ability to withhold claims payments after certain timelines aren't met in terms of the updates and the responses to provider directories, both the delisting as well as the actual withholding of payments for 30 days until they actually respond. I'm not aware if there's any data out there yet about how many plans have actually used that, but it certainly has increased the participation by the various specialty societies and other provider groups to work with the providers in the state to up their game and respond to these requests. So just something to think about.
Thank you.
Okay, thank you for those questions. And at this time, I would like to thank our panel for the discussion on provider directories. If you would like to evaluate this session, go ahead and take out your phones or on your computers, select A and follow the link. It is time for a quick 15-minute break, so please return promptly at 2:30 for our next session. And remember, for our viewing audience, if you have questions, go ahead and send those in via the SurveyMonkey link. Thank you.